Welcome to In the Trenches. Quick talk for a Thursday afternoon. My medical student wanted me to discuss abdominal aortic aneurysms, so-called AAA, and this is a very brief talk, and I'm going to talk a little bit about thoracic aortic aneurysms also, because they're really different. Abdominal aortic aneurysms are infrarenal. And you don't want to miss this diagnosis because they could rupture. And if they rupture, there's 90% mortality. And really what determines what they're going to rupture is their size and the rate of growth. What is it? An aneurysm is a dilated blood vessel. It's a bulging of the blood vessel due to weakness. Okay, and classically the bulge would have to be about 1.5 times greater than the size of the aorta in this instance. On exam, these you're going to theoretically look for a pulsating, an expansatile, not a pulsatile mass. So you're going to look for it to go this way if you feel it. Now, you could easily miss it, but it's not. If you feel just a pulsatile mass, you can see that in a lot of thin people. And if you suspect that, normally the first test is an ultrasound. Sometimes you get a CAT scan. And if they're having pain and they're symptomatic, they're going to have to be evaluated right away if they're in the office, or going to have to go to the ER. If they're in the ER, they're going to have to be imaged. The symptom would be abdominal pain. Patient with abdominal pain, you do not want to miss this. The classic size for when you're going to operate, when the risk of an aneurysm rupturing is about 5.5 centimeters. 5.5. Bigger than this, the bigger it is, the greater the risk. Some people would use 5 centimeters or a growth of greater than 0.5 centimeters per year. Okay, it's important to distinguish this from thoraco or thoracoabdominal aneurysms, which is above the bifurcation. It's above the renal arteries. The pathophysiology is different. With abdominal aneurysms, it's atherosclerotic and inflammatory, not thoracoabdominal aneurysms. With the aneurysms of the aorta, although they can rupture, you worry about dissection. And the pathology there is medial degeneration. And the classic acquired disease that does this is poorly controlled hypertension. But they're fibrinolopathies, congenital disorders that could cause this. The most common being Marfan syndrome, where you have abnormality with the fibrillin 1 gene and the walls are weak and you don't have elastic tissue there, and it could predispose to dissection or possibly rupture. Another condition is Loeys-Dietz syndrome, and these people, they could rupture or dissect or rupture at a much smaller size, and they have, they're younger people, they have hypertelorism, their eyes are separated, there's certain phenotypic features, and there are other conditions. So Marfan's the classic one. The classic acquired one is hypertension. With this, it really depends whether the aneurysm is before or after the great vessels. If it's before the trifurcation, usually 5 centimeters is the cutoff, and after the trifurcation, it's 6 centimeters. And if someone's acutely dissecting, that's a medical emergency. They're going to need to be stabilized. They're going to need to be placed on medicine like beta blockers. And after they're beta-block, positively vasodilators decrease the DPDT, or the shearing force across the aorta. Once they're stabilized, you take operating on them. For abdominal aortic aneurysms, it's different. This is atherosclerotic inflammatory. This is due to medial degeneration. And the procedures, they're doing endovascular procedures. Now, these are usually repaired. So from the get-go, abdominal aneurysm, somebody, usually they're older, they may have a smoking history, more common in men, and they're having abdominal pain, and you can't figure out what it is. You need to evaluate for this. And if you detect it, you need the size, and you need to evaluate for surgery. Thoracic and thoracoabdominal aneurysms, where it goes all the way down to the abdomen. That's a different condition. That is not atherosclerotic. Involves medial degeneration, which could potentially cause an intimal tear. And that's it.